my story is just like all of you. The reason why you're here, it's for a most horrible, terrible reason. And that is that your furry loved one has a disease. And this disease, for most of us, might be osteosarcoma. At least that's what it was for Ranger. He was just shy of 7 years old back in 2019 and came up limping after chasing a ball. And of course, I thought it was just a normal injury. It ended up being diagnosed as osteosarcoma. Horrible news and with terrible outcomes normally. And so as all of you, you're searching every way that you can. I went with the normal care that was with chemo. He had 4 rounds of carboplatin. He had his leg removed. It was a front right leg removed where the cancer was. And after that, those 4 treatments of carboplatin, just as they said it might, the lung mets showed up. And so it felt like everything that I had done up to that point was not going to work, that the prediction of maybe 6, maybe a year more would come about. So then you start searching, and I searched. First of all, Ohio State University had a clinical trial going on with what was called PAC1, procaspase 1 trial. It was a drug, pretty powerful drug, because for me to handle it, I had to use gloves. And I administered that to him for a week. And then the next week, I would take him up to Ohio State, and they would give him another infusion of chemo. So we did this 4 weeks in a row, or actually 8 weeks in a row, of alternating the chemo and then the drug. It was doxorubicin, the other kind of chemo. All through that, the lung met kept growing. And that's when I searched, and I had started communicating with Dr. Mamula. And again, I'm going to tell you right now, he's the most compassionate person there is. He's had a dog go through this, and he is searching in every way possible to save our dogs. So I called him, and I did not think it was going to be possible. He had already been through a clinical trial, and normally that would have excluded him for anything else, for anything scientific. And Mark said, we would love to have Ranger in this trial. We are especially interested in dogs with lung mets. And so in November of 2019, I took him to my vet to get the vaccines. He had a shot the first week of November, and then in the 3rd. Month later, his lungs were checked, and the lung met had stopped growing. And in 2 more months, the lung met was gone. It was completely gone. I got another 3.5 years with Ranger. I had to put him down just in January. Still tough. But because of the vaccine, which I am a wholehearted believer in, I'm a believer in Mark, it gave me 3.5 more years with a wonderful dog. And I think that you all are searching for the right way. Dr. Tripp, I greatly appreciate you being a participant. I hope that everybody will be a participant, and that this Mark's development of this vaccine will be widely available to everybody as a possible therapy. So that's my story, and it gives hope, I think, to everybody. And I can tell you right now, Mark has worked overtime, unbelievably hard, gone through all kinds of hurdles and roadblocks to get this done. And to his honor, and that he keeps at it, and he's fighting for you and your dogs. And Mark, I greatly appreciate that.
Thank you. Rick, that was perfect. Compelling story, of course. You've become a good friend, of course, over the years. We've, both you and I and Mary and many of us here have had unfortunately, many of the same experience in having lost our pups from cancer. Like to think it makes us stronger, makes me work harder. But probably more important for me in having developed this therapy is I've also obviously been a patient, had a dog as a patient with this terrible syndrome, cancer, of course. I'll assume some of you know about our work, some of the details, but I'll speak to those of you who may be new to what our therapy is. I'll only provide really brief summary of what the therapy is. If you would like fine detail, there's a publication that our group at Yale University had published about a year or so ago now that will give you or bore you with much of the very fine detail in this therapy. Simply put, this at its fundamental level, this is a therapeutic vaccination strategy. It is composed, the vaccine, which is much like any other human or even canine vaccine. It's a simple subcutaneous vaccination and a booster vaccination 3 weeks later. Subcutaneous between the shoulder blades. The premise or the strategy here is to develop an immune response, antibodies in particular, and also another bone marrow cell called T cells that are directed against, that attack the proteins that attack the tumor cells themselves. So the very simple biology here is that an immune response to the tumor will prevent growth of the tumor, will prevent signaling pathways that find their way to the tumor that typically cause the tumor to grow and divide. It helps block those pathways, and hopefully it even can or will eliminate tumor cells. This is based on successful human therapies, notably things you might find in the public domain called Herceptin or Erbitux. These are what are called monoclonal antibodies that are successfully used in many human cancers. These are antibodies that our therapy tries to emulate by natural vaccination. And in fact, we've now shown and published those comparisons in a recent paper. So we're really making use of medical science that has been forged by other research groups in developing this therapy for dogs. It, much like any other vaccination strategy, the outcomes or the effects are not immediate. The therapy relies on the dog making antibodies, just like in humans, if you get a vaccination, whether it's measles, mumps, COVID, it will take, on the average, 2 to 3 weeks for you to make an immune response, antibodies in particular, to that vaccine. Such is the case in this therapeutic vaccination in dogs. We can measure antibody responses to the tumor proteins that arise over about 3 weeks. They continue to expand and get larger over the successive 3 or 4 weeks after that, and then plateau and will largely remain elevated for almost a year in our studies. Again, the goals of our therapy, as you can imagine, are to either slow tumor growth or stop it, even better, or the best outcome, of course, is in reversing or eliminating tumors from the dog. We've had all 3 of those outcomes that we've observed in patients of ours. I will say up front, I don't try to sell this as a therapy that will necessarily be successful in every dog. Dog tumors, even the same kind of tumor in individual dogs, can grow very differently. And this is true in human cancers as well. There is not one therapy, as we all know, in human cancers that are effective in the same cancer in every patient. And that is the case, of course, in dogs as well. I oftentimes, well, the most often asked questions are, how will this work in my dog with osteosarcoma or hemangio or a number of other appropriate tumor types? And how soon will I see improvement? Again, as I mentioned, it's not an immediate therapy. It will take several weeks to develop antibodies. Those antibodies hopefully find their way to the tumor and start to be effective. We see a range of responses in terms of timing. Some dogs may have objective responses after 4 to 6 to 8 weeks. Some take longer. And of course, some dogs honestly don't respond at all, in part because there are factors about the tumor that allow the tumor to survive, simply put. Cancer, as I am constantly reminded to tell people, is a very dynamic disease. It's a changing disease over time. It's not one cancer cell that divides and makes identical cancer cells that grow into a large tumor. Tumors want to survive. They don't want to be killed by chemotherapies or by immune therapies, such as our vaccination. They mutate. So it's a very dynamic process. It changes over time, so it can better survive, it being the cancer. So it's a constant war, a battle, if you will, in how our immune therapy can potentially eliminate new mutated cancer cells over time. So with that, I'll just tell you that at the moment, our therapy is offered at Dr. Chelsea Tripp's clinic, the Bridge Animal Resource Center in Seattle. She'll talk to you here in a minute. It is also available at the University of Washington by Dr. Rance Sellon, and hopefully in a few other places in the coming days. And with that, I'll turn the microphone over to you, Dr. Tripp.
Sure. Rance would kill me if I didn't correct you, but it's Washington State University where he's at. University of Washington is just down the road from me. So he's closer to Idaho in that area of the state. So, but it is a haul for many of our clients, and we completely understand. I was actually part of the original Listeria vaccine that has been on the marketplace a couple of years ago for immunotherapy. And so we've been very focused on trying to add immunotherapy as the next pillar of care for our cancer patients. And that's probably a really good segue to what Mark is saying, in the fact that immunotherapy is going to be another strategy. It's not probably going to be the end-all be-all answer to curing cancer, but we need to use it still with surgery. We need to use it still with radiation. We need to use it with chemotherapy. And one of the things we learned quite a bit in that original clinical trial was the earlier the better for immunotherapy, because ultimately the immune system needs time. to take up that signal and to be able to promote the right cells to start to recruit to the tumor, whether it's the primary tumor or metastasis. So it's really important for us to try to plan in advance of when we're going to do this, rather than be looking at doing it late stage in the disease, because then we're a little bit behind. By the time the tumor has learned to get into other tissues, then you're fighting on multiple fronts on a war. Okay. So the more we can early diagnose our pets, the more we can get them heading in the right direction with immunotherapy. I think we're going to do better with their longevity and their responses. The cool part about this vaccine is what it targets, and the EGFR vaccine and the EGFR family of proteins and receptors has a lot of crossover in cancer. There's a lot of different tumor types that actually have the EGFR pathways intact, mutated, or upregulated, which make it for nice targets. And I do think that there's also going to be a translation to how this works in people, because dogs are a really strong model for how we are going to treat cancer in humans. So ultimately, I think what we're trying to learn in the dogs is also going to help translate on the human side, and hopefully everybody can be used or benefit from this vaccine. We still recommend standard of care on these guys, and that is, again, a first discussion of osteosarcoma kiddos is surgery or no surgery. Okay, if they don't have surgery, they can still have the vaccine, but we do want to still maintain pain management for those kiddos, whether you are using it with radiation or bisphosphonates or oral pain meds and things. And so ultimately, making good decisions on what is right for your pet and what is right for your family and their lifestyle is really important. But the vaccine can play a role in that care. And it is 2 injections, 3 weeks apart. We know that people are traveling a very long distance to come see us. And so we are trying to make sure that you have your established care in your area with your oncologist. And we will see you for a recheck, go over the vaccine, get you the vaccine, and the next appointment's literally just a tech appointment to get that next vaccine and get you back home. So as soon as we can get other locations up and running, we will, but it does take some time to get signed off on for handling biologics and things like that, like this, and to know the study protocol. So I see questions flying by as I'm talking. I haven't been able to look at those. Mari, is there anything you want me to field for questions that you're seeing?
See. I think there's a question about having the vaccine before or after chemo, or after, yeah.
Again, my opinion, and I think Rance, as maybe the only other oncologist on the call today, would agree, the sooner the better on immunotherapy. And that is what we saw with the Listeria dogs. Some of them are my 3 to 4 year survivors, are the dogs that got it at the time of their amputation or shortly thereafter, paired with their carboplatin chemotherapy. We can do it at the same time. I don't like to give it necessarily if their white cell count is a little low. But Washington State's giving it at the same time as their radiation for pain. So ultimately, if we can get it early on in the course of the disease, so the sooner the better.
Can you predict which dogs are going to respond based on the blood tests?
That's a Mark question.
So to add to what Dr. Tripp has indicated, and we have not yet published this, is that yes, dogs can receive chemotherapies at the same time as vaccination. There is a lot of data out there, largely in the human vaccine and chemotherapy arena, that indicate that carboplatin and doxorubicin, 2 of the most commonly used chemotherapies for pups, don't interfere tremendously with antibody or T cell responses. And this is true in studies in humans as well. And reiterating what Chelsea indicated, of course, is earlier the better, as one can imagine. Trying to think of other, did I miss some? Oh, there are some questions about, do I know if my pup has responded at least with an antibody, a measurement of antibodies after vaccination? The answer to that is yes. We can measure antibodies both before, well, we get blood samples before vaccination and after, and I can tell you from our experience that most all dogs respond to the vaccination. Very few do not get measurable antibody responses. It does happen, just as in human vaccinations. Not all human vaccines work in 100% of humans. But we can measure levels. We don't yet know what levels correlate with clinical outcomes. And as I mentioned earlier, just to reiterate, is that, again, a lot of the questions that relate to will my dog get better or response, which we all want to know, we just can't predict that based on good antibody responses or intermediate antibody responses. I can tell you from experience that we've had a lot of very good clinical outcomes in dogs that have what would be a marginal or even low antibody response to the vaccine. Conversely, we've had dogs that have had a very good antibody response that have not done well. So the correlation, this is what the clinical trial is designed to study, are the features of individual tumors in individual dogs, where the tumor may reside, whether there are metastases, other intangibles like the age of the dog, the gender, the breed. All of these things may make a difference. We just don't yet fully know with respect to our vaccine therapy.
How about
And
side
I
effects?
agree. I agree. Is that we're going to have multiple cohorts that come out of this in terms of dogs that had standard of care carboplatin at the same time as vaccine, dogs that were not amputated and had radiation and vaccine, dogs that have maybe done oral strategies instead of carboplatin and had vaccine. So there's going to be layers of dogs that we're going to get to look at to be able to say, okay, this group, how many did we have in this group and did they all do well? And maybe we can start to ferret out that information of which way is the best way. Probably the only thing drawback wise we want to try to stay away from is immunosuppressives like steroids and Apoquil and Atopica and things that modulate T-cell response, because we don't know that their response to the vaccine will be as strong in those situations. I have a couple kiddos that ultimately, sorry, those are my own children, ultimately have had to be on steroids. I have a little Boston that has osteosarcoma with pemphigus foliaceus as well. So I'm very interested to see how this dog does, because she has another disorder that requires her to be on steroids. So we are still looking at how to make the immune system respond the best way possible. So.
Can you say something about side effects that you're seeing and correlation of side effects, for example, lumps with the success?
Yes, absolutely happy to address that one. And we have studied this carefully. And these are from local patients here in Connecticut that have received our vaccine now several years ago. And some of them had passed away, and we had the opportunity to examine virtually every tissue out of dogs that received our vaccine. And in 5 or 6 or more now animals that we've examined, we see no, what we call in the profession, off-target effects. We don't see any bad side effects in other tissues. And we've looked at heart, liver, lung, brain, skin, kidney, etc. So we don't see inflammation or any abnormal, pathology in any other tissue. One side effect that I personally consider minor relative to all of the things that dogs go through, including things like amputation or other surgeries and chemotherapy, is inflammation at the site of the injection site. And as Dr. Tripp can address, this can be, from our experience, it only happens in about 20%, maybe 25% of the dogs that receive our vaccine. It can be anything from a small lump under the skin where the vaccine was applied, and that can be like a marble-sized lump. It can also get larger, even as large as a golf ball, and it may even leak a sticky fluid. The fluid is not tumor. It's not tumor growing. It's not infection. The vaccine is perfectly sterile. What it is white blood cells, or certain classes of white blood cells, primarily neutrophils, that come to the site of the vaccine and start to nibble it, for lack of a more appropriate scientific term. And that's actually a good thing. That's what starts the immune process. But don't be discouraged if you don't get the lump, as they call it, because immunity still can arise. And it's similar to your arm getting sore when you get a vaccination. That's actually a good thing. It means inflammatory cells, immune cells, are there sampling the vaccine.
Our role here is primarily going to be to serve a population of dogs that, for any number of reasons, are probably not going to get amputation and chemotherapy. We are one of the, in fact, I think right now we are the only facility in the state of Washington that can offer radiation therapy. There is a facility in Oregon, but with limited radiation therapy facilities in the Pacific Northwest, we have a really busy radiation therapy service. And one of the alternatives to the treatment of osteosarcoma dogs, alternatives to amputation and chemotherapy, is what's often referred to as palliative radiation therapy. The palliative radiation therapy is directed at the primary tumor site, and it is very effective at alleviating pain in these dogs. We often add another drug, a bisphosphonate called zoledronate, which has a bit of evidence to suggest that it can, in some dogs, help with pain management, may have some, and I emphasize may have some anti-tumor benefits. So our population of dogs enrolled in the trial are predominantly those that are getting radiation therapy because, again, for a number of reasons, they're not candidates for amputation and chemotherapy. Because of university regulations, what's called IACUC, Institutional Animal Care and Use Committee, we can actually offer the vaccine to two populations of dogs. That is, dogs that have been referred to us for palliative radiation therapy, or dogs that get limb amputation and chemotherapy. Our protocol says that dogs have to be treated with quote standard treatment, and the standard treatments for osteosarcoma, as has been alluded to, are limb amputation and chemotherapy or palliative radiation therapy. Because we are a university, and when one is dealing with things that are under the umbrella of what is called intellectual property, this would be Dr. Mamula's intellectual property, attorneys get involved. And as a result of that, we have what's called a materials transfer agreement, which says essentially that the vaccine has to be administered under, I'm going to say, my direct supervision. I don't have to be the one to administer it, but vaccines have to be administered here at WSU, which means that for people who come here for palliative radiation therapy and get the vaccine, they are obligated to come back 21 days later for the second vaccine. We can't send a dose of vaccine to their veterinarian to administer closer to home. That would violate our materials transfer agreement and could get us into potential legal difficulties with universities. So that's the basic overview of what WSU can do. We are actively enrolling patients. We just gave a patient a first dose of a vaccine on the heels of palliative radiation therapy yesterday. And I think, Mark, we've got, in the last 2 weeks, I think we've added another three or four dogs that were sent here for radiation therapy. So we'll see how things play out with them. I want to reiterate everything that has been said and maybe expand just a little bit. There's no guarantees of response to therapy. And part of the reason for that has already been alluded to, but I'm going to take another stab at it here. We're dealing with two dynamic populations. We're dealing with the dynamic population that represents the dogs getting the vaccines. And when I talk to students about immunotherapy, I basically have them go back and tax them to recall some very basics of immunology. And that is that all immune responses are genetically dictated. So a dog that doesn't have the appropriate genes to mount appropriate immune responses is not necessarily going to benefit from the vaccine, as Mark has already alluded to. And because of what's often referred to as dichotomy, the split, if you will, in the immune response, the antibody responses or the T cell or the cell-mediated immune responses, a dog could have a really robust antibody response, but have a less impressive T cell response. And if they don't have a good T cell response, then their ability to control or kill tumor cells may not be as good as one hoped for. Then we have the tumor, as Mark has already alluded to as well. Tumors are very dynamic things, and I tell clients all the time that when dealing with a metastatic tumor like osteosarcoma, the cells that set up sites in the lungs or any of the places that osteosarcoma can go, while it's the same tumor type, it's not realistic to expect that they are identical to the parent tumor. The fact that they can live in these new places makes them different. And as a result of that, it's often referred to as plasticity, as a result of that ability to change over time.
I just booked an appointment
The expectations
for the
that
29th.
the vaccine
I have a
will
booking number.
be a benefit to all
And it
patients in all
didn't give me a
situations
chance
is probably
to
not realistic.
choose what.
Apologize for that. It's Washington State University.
You won't be the first and you won't be the last.
And I can just say that I'll tell you from a personal perspective, and I'm an immunologist by training. I'm not a veterinarian. I'm part of the Yale Cancer Center. So in that sense, I follow oncology closely and carefully, but we're really enthusiastic about the utilization of this therapy with other existing therapies. Dr. Sellon is pioneering palliative radiation. And I think we would all agree that if successful, that really is potentially a game changer for, allowing dogs to keep a limb. And there are probably many clinical situations where dogs can't have amputation, and this is certainly an exciting field. But again, reiterating what Dr. Tripp mentioned is that there are therapies out there. We're one of them, and we would like to add to the efficacy, to the good outcomes that are already appreciated by some of the existing therapies. This is true in human cancer care as well.
I just want to clarify, just for transparency, I'm not a radiation oncologist. And so I rely on the help of Dr. Janine Fidel, who is both a medical and radiation oncologist here at Washington State. And she designs the protocols that have been in place for a number of years for our radiation therapy patients. And so we're just dovetailing the vaccine into the existing radiation therapy protocols that Dr. Fidel, in conjunction with Pat Gavin, former radiation oncologist here at WSU, did quite a number of years ago.
I see some questions on some other tumor types. So osteosarcoma and hemangiosarcoma are our go-tos at my location. But ultimately, we do have some carcinomas that we are able to treat as well, specifically UC or TCC, transitional cell carcinoma or urothelial carcinoma, as it's been renamed, has very high EGFR expression as well. So I have had a handful of those other types of tumors. The majority of what we've been treating so far has been osteosarcoma and hemangiosarcoma kiddos. And again, we started with this trial around Thanksgiving. So we're still very early in the process of being able to look at those dogs and seeing how they're doing clinically. But I think it's very promising as an adjunct for UC TCC cases as well as the hemangio kiddos. So.
And I should probably add that at WSU, our IACUC approval, our IACUC protocol right now mandates that we only give the vaccine to osteosarcoma bearing dogs. And even with that, dogs with appendicular osteosarcoma and not osteosarcoma of what's often referred to as the axial skeleton, things like the skull or the shoulder blades or the spine or the pelvis bones. Our IACUC approval is only for appendicular osteosarcoma in dogs, which represent the vast majority of osteosarcoma bearing dogs anyway, and they reflect the majority of what we see here at our hospital.
I'd like to ask a question just real quick, and that would be that I know that the results are coming in, but you've only been giving the vaccine for a while. I was wondering if any of the dogs that have shown metastatic cancer, like to the lung or anywhere else, have they been resolved? And I'm asking that question just because my dog had that cancer resolved within 3 months. I mean, he had a lung tumor, and with 1 month, it had stopped growing, and within 2 more months, it was gone. And I was wondering if either one of Dr. Tripp's or Dr. Sellon's dogs, if any of you have had metastatic cancers gone to other organs, and if they've been resolved also.
I have a handful again of known metastasis. Our protocol is that they have to have chest filmed within 30 days of the vaccine to know where their status is on their lungs. And if they don't have that, then I take them a day of for their first vaccine. And I've had a couple that have traveled to us that unfortunately, when they came, they do have visible metastasis. Now, again, those are dogs we have to follow out, and we're barely kind of 3 to 4 months in here. So similar to Ranger, I expect we may know the answer to that by summertime on some of these kiddos. But yes, known metastasis is still a possibility. Ideally, we would try to catch them early on in the process with 1 or 2 small nodules versus kind of a whiteout effect happening in the lungs, or if they're clinical, because of the lag time that it takes for the immune system to take the signal. It's a race between what the cancer is trying to do and what we can get the immune system to start to recognize. So the sooner the better. And we are trying to get you in as quick as possible. As you can imagine, getting anywhere in veterinary medicine right now is challenging. From a caseload standpoint for ERs and specialty centers, and even your GPs are refusing to take new exams and things like that. So we do recommend you give us a call, and we try to work with you to try to get you in as quick as possible based on what's going on with your kiddo and when surgery's happening and things like that.
My daughter Katie is on the line, and it reminded everyone that warm compresses help the so-called sterile abscess resolve. And that is, in fact, the experience that's been shared to me by many of those that have had our vaccine and that get a lump under the site of the vaccination. A lot of patients will use those hand warmers that are often used in the wintertime. A warm compress about 20 minutes twice a day or 3 times a day if you can, help it resolve in usually within a couple weeks is our experience.
Is there a wait list for OSA dogs to get the vaccine in Washington State?
Is that
was or with us?
Either of you, both of you.
No, we've gotten through the wait list, and they call, we get them scheduled.
Okay.
And people calling us are at the mercy of our appointment schedule. Again, as one of the few radiation therapy facilities in the Pacific Northwest, there are limits to how many patients we can see and treat. And we see radiation therapy patients in addition to our medical oncology caseload. And so there can be a bit of a wait. That said, our schedulers do try to put a priority on the osteosarcoma dogs because of their pain and discomfort. But we generally try, in most cases, if we get a call from a veterinarian that says they have an osteosarcoma dog that an owner's interested in palliative radiation therapy and they want to come see us, we try to get those patients in whenever possible within a week of the call.
And
Right.
Mark, I'm going to ask you, because this is a question that every one of these people that are on this line right now, is there a chance that this therapy will open up at other facilities closer to home for many of them?
You always get right to the important part of what we're doing, Rick. I've always appreciated you for that. Yes, we do have other clinics on board that are willing to be a part of this clinical trial. And ultimately, I hope part of the therapy as it evolves in the future as well. I'm trying to collect all of the sites to submit to the USDA at once for approval, as opposed to one clinic at a time. And again, it's mostly out of pure guilt that I experience at night of people having to drive long distances to the state of Washington. So we're trying to set up sites around the country. We will have one in your neighborhood, Rick, in Ohio, one
Great.
outside Cincinnati.
Oh, great.
Potentially one in Chicago, Virginia, Dallas, Salt Lake City. Let's see, I believe Michigan. And I'm looking for sites farther on the East Coast, New England at the moment. I can't yet tell you when those sites will go live. I think, as Dr. Tripp and Dr. Sellon know, there are criteria for this clinical trial. We want to get all of the data that we're discussing to answer all of these complicated questions. So it's not simply how quick can I get it to your vet. It's, can your vet provide the follow-up analysis, x-rays, follow-up appointments, etc., blood samples, all of those things which we're interested in.
One other important thing, it's often assumed based on a radiographic appearance of a limb, but for dogs at WSU to be eligible for the vaccine, we do have to have at least a cytologic diagnosis consistent with osteosarcoma. There's, depending upon the paper that you read, roughly 5 to 10 of every 100 dogs that has a bone lesion that looks like osteosarcoma will have a different tumor type. And so we want to make sure that we're giving the vaccine to the right dogs for the right reasons. And aspiration cytology of the bone lesions is a fairly simple and straightforward procedure. It's not recognized to increase the risk of pathologic fractures. And we find that we are often able to get a cytologic diagnosis suggestive of or consistent with osteosarcoma based on something as non-invasive as a bone aspirate using a simple injection needle.
I have a question. When you get a patient with a lung metastasis, do you also prescribe a propranolol, losartan, dasatinib combination that CSU and Tufts have been looking at? Either of you?
It depends on if the client's our client or traveled to us. We are being very respectful of what other oncologists are recommending for those patients and are really playing the role to serve, to get the vaccine and send them back to their oncologist. So it's very reasonable for them to ask those questions of their oncologist. I can say that I have prescribed that for some of my own patients here, but I'm not having a conversation about changes in their overall plan, just more to get the vaccine as part of their care.
Got it.
And ditto for what Chelsea said for us. Yes, we have done various things for dogs with proven metastatic disease, including tacrolimus, losartan, other chemotherapy approaches. If something doesn't work, we'll try something else. But for dogs that are under the care of another oncologist, we defer to the protocol and the plan that the oncologist has put in place.
Okay. There's a couple of questions about potential clinic opening in Canada and also about cats. Maybe that's for you, Mark.
Canada, we hope to be there as well. I have negotiated import agreements with the Canadian Department of Veterinary Biologics that allowed us to be there in the past. I think that we don't yet have trial sites immediately in place in Canada.
It's a big country. How about cats? Do you think?
Oh, cats.
I'm sorry.
No, unfortunately not in cats for a number of complex biological differences between cats, dogs, and humans. So at the moment, we're taking baby steps into getting the data in dogs.
For owners that live in British Columbia, potentially Saskatchewan, we are accessible. Dr. Tripp's practice is accessible to Vancouver, for example. There's a big population center there in British Columbia, and she is closer to them than WSU is. But we actually had a patient that had come to us for the vaccine from a community in British Columbia. So yes, we can take patients from Canada, but obviously they have to come to WSU or they'd have to travel to Edmonds and Dr. Tripp's practice.
I'll briefly address the cancers that are not appropriate for our particular therapy. And those are the so-called liquid tumors that include lymphomas and leukemias. And then the other tumor types that we've talked about, I won't reiterate, but we've selected based on the known expression of this family of proteins called EGFR HER2, either in veterinary practice, veterinary patients, or in human patients when they haven't been necessarily or carefully studied in dogs.
I think some of the pet parents are faced with a difficult decision of trying to see if they could drive to Washington State or wait till a clinic close to them opens. So is there any kind of timeline that you could share?
The USDA has been quite efficient, I guess, as a government agency goes, with approving, well, originally, of course, BARC in Seattle and Washington State University as well. That I assume they will be efficient when asking them to approve other sites. But again, some of these things are out of my direct control. So I've quit predicting how soon I can get these online. You know, again, I'm trying to reduce my interaction and paperwork with the USDA by submitting multiple sites all at the same time. I will tell you, I guess there's a chain of veterinary clinics that we're trying to get on board. The bureaucracy there is a little bit more difficult than individual institutions, but there is an economy of scale there in being approved for all of their sites. So that's in part what what I'm waiting on in approving new sites for clinical trials.
Mark, also, could you share some of your data, early data for hemangiosarcoma?
This is literally being written up as we speak with Dr. Hester Doyle in our group, that is really the important person behind all of this work. She analyzes all of the serum samples, does all of the careful molecular studies that we do, tissue pathology, immunohistochemistry, all of that. So all of that is in her lab. I try and stay out of her way, honestly. I can generically say that the outcomes in hemangiosarcoma, similar to osteo, appear to be statistically significantly better than standard of care. Hemangiosarcoma, I'm sure, as the practicing veterinary oncologist here will admit, is a very difficult, a very aggressive disease that is very dependent on individual dogs. I can tell you frequently, unfortunately, a lot of people contact us or get involved in the program far too late in the game for a lot of these aggressive cancer types. So with that said, I think there was also another question whether this would be a, quote, healthy dog vaccination to prevent tumors in the future. The answer is no, not yet. We do know that the immune response to this vaccine starts to subside, starts to get lower after about 12 or 14 months, frequently requiring an additional third vaccination. That's our experience. We haven't yet published that either. But again, similar to the COVID vaccine, where a similar outcome is observed, where antibody responses start to decrease after 8 to 12 to 14 months, such is the same as it appears with our vaccination strategy.
I just want to add one other comment about the vaccine and mostly what's not known at this point. It needs to be understood that the EGFR receptor is a part of normal physiology. And I think it's inevitable, my opinion is, and I don't want to sound too pessimistic about this because I see a lot of promise in the vaccine. I wouldn't be a part of the study if I didn't believe in the promise and potential. But I think it's inevitable as more and more dogs get the vaccine that we're going to start to appreciate occasional dogs having adverse effects to the vaccine that have not been described yet, that have not been appreciated. And when one considers that the EGFR protein is a normal part of mammalian biology, this potential spectrum of adverse effects has the potential to be quite big, in all honesty. Thankfully, we are not seeing that yet, as has been alluded to, but again, I think it's inevitable that as more and more dogs get the vaccine, that there's going to be occasional dogs that have adverse effects or have an adverse effect from the vaccine. What that might look like, we have no idea. So along that line, then I would ask that for owners of dogs who do get the vaccine, that if you see something in your dog or your veterinarian sees something in your dog and you're not sure what's happening, to communicate with one of us to get a sense as to what the potential likelihood of a vaccine adverse reaction might be. I'll say honestly too that in some situations, the conclusion that something is a consequence of the vaccine may come from excluding other potential causes first. But I'm optimistic for the vaccine, but I'm also a realist at heart as well. And again, it's inevitable, just as we learn from COVID, as we learn from every new vaccine, the bigger the population that gets the vaccine, the greater the likelihood that at some point there's going to be a problem or an adverse effect with the vaccine.
I absolutely agree with you, Dr. Sellon. And hopefully this clinical trial will bring those to the surface. I can tell you from personal experience that I've had comments from many of our patient families, which now number over 500 or so, that some will indicate my dog lost his appetite, or my dog is eating more, or my dog seems livelier and more energetic, or my dog seems more tired. All of these anecdotal comments, while we record them, I can't formally ascribe any of these opinions to real science. Regarding the other potential side effects, we do benefit from what's known about side effects with other EGFR therapies in human cancer, notably the monoclonal antibodies, which I think in human cancer, it's very clear that when it's utilized, typically the benefits far outweigh the risks there. But having said that, you're absolutely right that the EGFR protein didn't evolve to exist only on tumor cells. It has biology that's important to other tissue systems, organ systems as well.
I'm just going to be the advocate for all these people who are like me. Got a little bit of a science background, but not like you guys. And of course, when we first sit on an oncology appointment with our dog and they tell us, well, the therapies that are available, you'll get 6 months, maybe a year. And that's not what we want to hear. We want to hear that our dogs will live much longer. And of course, we've gone through chemo, we go through either the radiation or we go through amputation, and we may go through other things. But the bottom line is we want more time with our dog. And I believe, and I think the reason why all three of you are involved in this is that you believe also that this has a chance to give us those longer years, days with our dogs. And that's what we're seeking. That's what we're looking for. And for Mark to have developed this, because I can guarantee everybody who's listening to this is his same goal. Mark lost a very, very dear dog to him. And if we both talk about it, we both begin to tear up. And so same thing with Mari. And so there is a reason, not monetary at all. It is all based on that he wants to solve this problem, this horrific problem for all of us, for losing our dogs. And yeah. So you're on the right track, I think. And again, I'm hoping that the two facilities here will find very similar results, that it's not a surprise to anybody anymore that this vaccine works. And I don't think Ranger was a outlier. I think Ranger is going to be the middle of the road of how this vaccine can help our dogs. Gave me 3.5 more years with him and resolved a lung met. And to me, that's remarkable because that's not what I heard prior to getting the vaccine.
Respect to Mr. Rick's comment about metastases. Do you ever see dogs resolve metastases with chemotherapies? And if you do, how frequently?
That's an unusual scenario, I would say, where we actually do get the benefit of seeing resolution of visible metastasis. And ultimately, I've thrown a number of drugs at lung metastasis for osteosarcoma, and I've probably maybe only stabilized things to a certain degree in patients over the years. So to actually get a visible resolution of metastasis is not something I've experienced with non-traditional or traditional drugs in my clinical practice.
I don't have an experience different from Dr. Tripp's, and collectively, I can't think of situations where my colleagues have seen reduction, certainly not disappearance of existing metastatic lesions in response to, I'm going to call them conventional medical therapies, which could encompass things like chemotherapy drugs or other non-radiation, non-surgical approaches. I generally tell clients that if a dog has visible metastasis and we can keep their disease stable, that's a victory for this tumor and that clinical status. That said, I'm fond of telling owners too, as an oncologist, people ask us all the time, what's the longevity for my dog? If I pursue this particular treatment? And the honest answer really is, I don't know. For your dog, that's the honest answer. I don't know, because we can't predict what the behavior of the individual dog is going to be based on anything derived from population-based statistics. The numbers that we throw out come from and describe populations of dogs, and they can't describe or predict what's going to happen with the individual patient. For example, we generally tell people that if a dog has palliative radiation therapy for an appendicular forelimb osteosarcoma, that typical survival times before the dog either succumbs to complications of intractable pain, either because analgesics or radiation therapy aren't working anymore, the dog has a pathologic fracture, or the complications of metastatic disease, generally within about 6 to 8 months. That said, just late this past fall, I had a communication from a veterinarian whose dog we treated early in the COVID pandemic in March of 2020. She brought her dog to WSU for palliative radiation therapy, and the dog didn't get the vaccine, didn't get any chemotherapy, didn't get anything else other than palliative radiation therapy. And that dog, the dog's name was Walter. Walter lived for a bit over 2 years with nothing but a single course of palliative radiation therapy. That would not have been predicted based on the population, but nonetheless, that's what this veterinarian's dog experienced. And there's no way that I could have predicted that based on anything known about the dog or the disease. So I make it a point when I tell clients, when you ask me those questions, I do not know. I do not know how to answer that question in a reliable and predictable way, because any figure that I give you is likely to be wrong. And I've made the mistake of being wrong enough times that I know the taste of my toes all too well from having my foot in my mouth, and they don't taste very good.
So Professor Sellon, Mark and Chelsea are now starting in collaboration with Oregon State University. They're collecting extra blood sample and fecal swipe samples to look for biomarkers in microbiome and in blood to be able to correlate and predict who's going to be responders and non-responders. Is that something that you might be able to participate in at? I understand you probably have to change your IACA, but is that something you might be interested in participating in?
If we had the appropriate indications and knew what the protocols were, what the samples were,
Okay.
best I can say is that we would entertain that possibility.
Okay, great. Thank you. Do you have like 10 minutes after this call to talk to us?
In fact, in about 5 minutes, I've got a patient of my own that is showing
Okay.
a patient of mine that I'm supposed to see here. So I'm
All
going
right.
to have to leave in just a few minutes myself.
Okay, thank you. Thank you. Well,
Mark, I put a link for the paper that you've published on this, but I think, again, everybody is on this Zoom meeting to hear for hope. And those 500 dogs that have been participants in this study prior to the two in state of Washington, can you give them a brief idea about the results so far as to the outcomes? Again, a few dogs I know had lung mets resolved, but many, many more have lived beyond the year, 6 to 8 months or whatever with the vaccine. Can you give anybody any hope as to those results?
I'm happy to discuss what we've published and even what we've not published. So a weakness of our past studies is in not having had regular radiographs, x-rays taken among our patient populations. Those things were difficult to control among the original group of participating veterinary offices. However, we did get regular x-rays done by enthusiastic and thoughtful families for their own pets. And what I did report was 3 cases in the original study and an additional 3 cases that we have not yet published of carefully done regular radiographs that indicated either static lesions that don't change in size, and that was in 1 of the 6 cases, and the other 5 cases found either partial or full regression. Now, I'm very careful to interpret these in that, the interpretations are from different radiologists, et cetera. I don't interpret any of these on my own. These are from board certified radiologists. But having said that, it's certainly a topic we're very interested in, I'd personally be interested in having participating clinics recruit those patients because, of course, and I think Dr. Sellon will agree, that's the main source of morbidity and mortality in osteosarcoma.
And this is a last comment that I think I'll be able to make. For dogs that have limb amputation and chemotherapy, those dogs inevitably, the vast majority, succumb to complications of metastatic disease. Osteosarcoma tends to go to lungs, but it can end up in other places. I just lost a patient that had really bad bone metastasis. And in fact, bone metastasis was its first indication of a problem when the dog who had had a limb amputation and chemotherapy came in for a follow-up visit, and the owner said, "We think he bumped into something because he's lame in his left foreleg now." And as an oncologist, knowing about osteosarcoma, that was a big red flag. And sure enough, the dog had a metastatic lesion to a bone in that leg. And the dog had radiographic evidence of other bony lesions at that point as well. For the dogs that have radiation therapy, as I mentioned earlier, there are typically 2 reasons for those dogs to be lost to the tumor. The radiation therapy doesn't necessarily slow the growth of the tumor down at the primary tumor site. And as the tumor continues to progress locally, the dogs become susceptible to what's called a pathologic fracture, which is a fracture that happens as a result of bone disease. And typically when that happens, the only recourse for mitigating pain in that dog is limb amputation. And oftentimes there, again, are reasons why the dog didn't have limb amputation to begin with. And so the development of a pathologic fracture can be a life-ending complication. For dogs that respond really, really well to the palliative radiation therapy, they can go on to develop complications of metastatic disease. And it does become a bit of a race as to which is going to be the dogs undoing the metastatic disease or the intractable pain / pathologic fracture that can be created by the primary tumor. So we see from our patient population that gets radiation therapy, we see both outcomes. My assessment from all the patients we've dealt with is that more dogs that get palliative radiation therapy succumb to local disease problems, intractable pain, or a pathologic fracture than from metastatic disease. But every once in a while, we get the dogs that respond really, really well to radiation therapy that the metastatic disease emerges first. So thanks everybody for your attention. I've got to go. Appreciate your interest. And we're excited about this new tool that we have. I want to emphasize again, to be used in addition to other standard treatments. And we're hopeful that as we recruit more dogs, that we can show that there's a benefit in the population of dogs that get the vaccine. And Mark, thanks for your contributions. Mary, thanks for organizing this. And we'll keep our fingers crossed.